Good afternoon, everybody. Start, Jecha. Good afternoon, everybody. So we have completed the geriatric health in India, and now we are coming to the topic of tribal health in India, which is an emerging subject of interest. So this is contents. So what is the definition? Adivasis, Devanagari, literally old inhabitants, is a term used for all the heterogeneous set of ethnic and tribal groups believed to be the aboriginal population of India. Officially recognized by the Indian government as scheduled tribes in the 5th schedule of the Constitution of India, they are often grouped together with scheduled castes in the category scheduled castes and tribes, which is eligible for certain affirmative action measures. So scheduled caste is 16.8% of the Indian population, and scheduled tribes is 8.6% of the Indian population as per 2011 census. So their distribution. So MP, there are 15 million population. Maharashtra, 10 million. Odisha, 9 million. And Rajasthan, 9 million. But there's a major chunk of tribal population are located in the states of MP, Maharashtra, Rajasthan, Odisha, and also Jharkhand, plus northern states. But in northeastern states, the percentage of tribals to the population is around 80 to 90%, whereas here in these states, it is 5 to 22%. Odisha is having 22% of the population. So more than 2/3 of the population lives in 7 states. That is Chhattisgarh, Jharkhand, Gujarat, and concentration of tribes is highest among Northeast. And 90% of tribal population lives in the rural areas. They are all basically rural areas. They can't be urbanized. The tribal population lives predominantly in the hilly and forested area. They are scattered across large areas with low density of population. Growth of scheduled tribes population. In 2001, it was 8.2% of Indian population. Now it has grown to 8.6%. And total fertility rate amongst the tribal population in our country is 2.5. And sex ratio, you can see it is a very healthy 990 per 1000 population. So when you compare to Haryana, which is 874 to 1000. So sex ratio is far, far better amongst the tribal population. So this is a world map. I don't want to expand, but you can see very boldly Gujarat, Karnataka, Orissa, Bihar, and then northern states. The population distribution. Tribal peoples constitute 8.6% of the nation's total population. In the northeastern states of Arunachal Pradesh, Meghalaya, Mizoram and Nagaland, 83 to 90% is tribal population. In fact, Arunachal Pradesh, it is 92%. In the remaining northeast states, that is Assam, Manipur, Sikkim and Tripura, tribal population share is between 20% and 30%. Central Indian states have the country's largest tribes, and taken as a whole, roughly 75% of the total tribal population live there. Though their numbers as percentage of total population of the state is less, but as such, in gross numbers, they are very high in Central Indian states. One concentration of tribal population lives in a belt along the Himalayas, stretching through Jammu and Kashmir, Himachal Pradesh and Uttarakhand in the west to the northeast. Another concentration lives in the hilly areas of central India, Chhattisgarh, Madhya Pradesh, Orissa, and to a lesser extent Andhra Pradesh. Small numbers of tribal people in Karnataka, Tamil Nadu, and Kerala in South India. That is alongside the Western Ghats and Eastern Ghats. In Western India, the Gujarat and Rajasthan. In the Union territories of Lakshadweep and Andaman and Nicobar Islands, there is a quite a good concentration of tribal population, but those small in numbers. So here you can see especially for a good health service to function optimally and effectively in any given society, literacy status is very, very important. You can see the literacy status. All India, it was 28.3% all in 1961. And amongst the scheduled tribes, it was 8.53%. So males and females. So you can see female literacy was around 3.16. And 1971, it was 34.45, and then in scheduled tribes, it is 11.3%. See, mind you, literacy in India, it is defined as ability to read and write with comprehension. That's all. So 43.57 in 1987. So like that, literacy rate among Indians, amongst the general population, is risen to 73%, whereas in scheduled tribes it has risen to 59%. Even today, there is a lot of disparity. So, another word about the socio-economic status. So, mainly agriculture, collectors of forest produce, hunters and herders. So, all three stages are there. They are food gatherers, hunters, and animal rearing also is one of them, and agriculture. So, all the four layers of human civilization you can see in this tribal population. So, dependent heavily on agriculture, 40% of the tribal population lives below poverty line. So, access to tap water is only 10.7%, and 74.7% of the tribal population, they take recourse to open field defecation. And as I have told you, illiteracy percentage is 41%, or otherwise literacy percentage is 59%, as per 2011 census. Only 6.7% of the scheduled tribe population above 18 years have completed 12 years of education. So you can see this, it looks very colorful, but their lives are not that colorful. Only that much I can say. Say some important tribes state-wise. Andhra Pradesh, we call them as Chenchus, Koyas, Gonds in Adilabad district, and Kondareddis in Khammam district. And in Arunachal Pradesh, we call them as Abors and Akoms. These are the predominant tribes. Actually, there are 713 tribes enlisted in by the government of India. And now in Assam, they are called as Burmans and Bodos. In Chhattisgarh, predominant tribes only I am taking. Small tribes will be there, many. So Assam, so Chhattisgarh, Agarias and Baigas, and Kerala and Karnataka, they are called as Adiyams and Baradas. In Mizoram, they are called as Chakmas. In Rajasthan and Gujarat, they are called as Bhils. In Jharkhand, they are called as Asuras, Baigas and Banjaras. In Odisha, also they are called as Baigas, and there are Saravas and then Baitadi. In Tamil Nadu, especially in the Nilgiri areas, they are called as Thodas and Sholakas. Tribal education. Efforts to improve the tribe's educational status have had mixed results. Recruitment of qualified teachers and determination of the appropriate language of instruction also remain troublesome. Many tribal schools are plagued by high dropout rates. Tribal health. Tribes usually remain isolated. Majority of them have poor health status and inadequate health infrastructure also. Deficiency of essential components in diet leading to malnutrition, protein calorie malnutrition and micronutrient deficiencies. Goiter of various grades is also endemic in some of the tribal areas. So nutrition status and maternal health. You can see here nutritional status under 5 years. Under 5 years, children stunted. In the general population, it is 43. In tribal population, it is 43.8%, and in general population, it is 38.4%. So, under 5, children wasted. In tribal population, it is 27.4%, and in the general population, it is 21%. Under 5 years, children underweight, 45.3 in the tribal population, whereas 35.7 in general population. So, maternal health. Only 68% of the mothers, even today after so much of encouragement, only 68% of the mothers are undergoing institutional deliveries in tribal areas, whereas it is somewhere around 79 in the rest of the country. Deliveries attended by skilled health personnel is 71.5% in the case of tribal population, whereas it is 81.5% in general population. And total fertility rate is around 2.48 in tribal population, whereas holiday average is 1.93%. 1.93, sorry, it is a rate. So couple using any contraception as percentage, say in tribal population only 49.4% use contraception, whereas here general population it is contraceptive usage works out 57.5% of the population. Now let us compare one advanced state with the tribal situation. So you can see infant mortality rate in Maharashtra it is 59. In Andhra Pradesh it is still lower. So infant mortality rate is 59. And in tribal population it is 110, almost double. Crude death rate is Maharashtra it is 7.9 per thousand mid-year population, whereas in the tribal situation it is 13. Third, maternal mortality rate it is 2 per 1 lakh population, 1 lakh live births, and tribal situation it is not available. Maternal mortality rate, 2 per 1000 years women, that is nearly roughly 2,200 per 1 lakh live births. So low birth weight babies in Maharashtra 28% of the babies are low birth weight, whereas in tribal population it is 40%. And family size, average family size is 3.8 in Maharashtra, whereas in tribal population it is 4.2. Delivery by traditional birth attendant, it is 86%. In trained birth attendant is 86% in Maharashtra, whereas in tribal situations it is only 12%. Now this slide I have already gone into that. So, and again let us have a look at infant and child mortality rate from another perspective. Infant mortality rate, general population, in tribal population it is 44.4, whereas 40.7 is in the general population. Neonatal mortality rate, it is 31.3 per 1000 live births, whereas general population it is 23.2. And post-neonatal mortality rate is 13.1 in the general population. In the tribal population it is 8.9. Under 5 mortality rate is 57.2 in the tribal population, whereas general population it is 49.7. And child mortality rate is 13.4 per 1000 live births in general population, whereas 6.6 in tribal population. So infants fully immunized, 55% only are fully immunized in tribal population, whereas even in general population we are not doing better. It is 62. Now people say it is 71% according to National Family Health Survey. And then no vaccination, and then measles 77.4% coverage in tribal population, whereas in general population it's 82.8. DPT 86.4% and 89.7%. At least DPT they are being well covered. And then polio also equally good, 87%. Anyway, in every index, general population is better. And then hepatitis B 78, and then hepatitis B3, it is 56.9, and then polio, zero dose, 74.5% are receiving it, and hepatitis B zero dose, 62.8% only. And pregnant women, tetanus toxoid, 79% in tribal population, whereas in the general population it is 85%. Now let us have a closer look at the health status of the general tribal population. Life expectancy 63.9 years as compared to 67 years in the general population. Maternal health, early marriage, early childbirth, and low BMI and anemia. 50% girls are underweight, and anemia prevalence is 65%, and full ANC coverage is only 15%, and institutional delivery rate is 70%, and 27% tribal women deliver at home. Infant mortality rate is 44.4 per 1000 live births. This is as per NFHS 4. So this is under 5 mortality in scheduled tribes, NFHS 1. So the under 5 mortality rate in others is shown in black, and in scheduled tribes it is shown in red. And you can very easily make out it is very high in tribal population. Though height of the towers is slowly coming down, disparity by and large it is remaining the same. So communicable diseases. The waterborne and communicable diseases, gastrointestinal disorders are very common, leading to marked morbidity and malnutrition. Malaria and tuberculosis also are very common. A spectrum of viral and venereal disease also is present. So prevalence of TB 703 per 1 lakh population as against national figure of 256 per 1 lakh population. And 8% of tribal population account for 30% of malaria cases and 60% of falciparum malaria cases reported from India. Out of 1,35,000 leprosy cases detected in the country in 2015, high numbers, that is 28,000, are from tribal population. Other vector-borne diseases such as dengue, chikungunya are relatively more common in tribal population than in general population. So disease burden of tribal population. So they are having a triple burden of disease. How? One is undernutrition and communicable diseases. The second is even hypertension. It is fairly high, and non-communicable diseases, and also disturbed mental health due to addictions, especially. The tribal people tend to get addicted to intoxicating substances very easily. So, communicable disease, malaria 30% of all cases, tuberculosis 703, just now I told, leprosy 18.5% of all cases. So, non-communicable diseases, hypertension, 1/4 of the tribal population suffer from hypertension. And then diabetes, it is not well known, well documented. And then sickle cell disorder, say 1%, 1% to 40%. Sickle cell trait, it is not sickle cell anemia, but sickle cell trait per se has got a reasonable prevalence, reasonably high prevalence in Indian scenario. And then G6PD deficiency, this is one of the common, very common genetically transmitted enzyme deficiency in the world, and it is 0.7% to 15.6% in different parts of the country. And nutrition is definitely undernutrition, and there are micronutrient deficiencies. So genetic disorders, high prevalence of genetic disorders mostly involving red blood cells. Genetically transmitted disorders like sickle cell anemia, just now I have told. So glucose 6-phosphate dehydrogenase deficiency and different forms of thalassemia are also common. Social and cultural issues, superstitions particularly related to health problems, extreme poverty and excess consumption of alcohol. These are the main spoilers of tribal health. So mental health and addictions, tobacco 72% of tribals are addicted to tobacco, and then alcohol nearly 50% are addicted to alcohol. So animal attacks and violence in conflict areas. So both are life threatening, at least, if not life consuming. So tribal health in Northeast India, high incidence of NCD and then high mental health problems, that is drug use, tobacco and alcohol. High HIV/AIDS incidence due to IV drug use, and malaria with a API, annual parasite index, above 5. So, burden of diseases on tribal health services. Now let us examine a little bit about the kind of health services provided in tribal areas. First of all, let us look on the minus side. There is communicable disease burden, there is non-communicable disease burden. Moreover, if patients on their own, they will not be able to come to a doctor because difficult terrain and harsh environment. And year by year, the socio-economic condition of the tribal population is deteriorating. As a result, they will not be having much to spare for health. And so poor quality and inappropriate health care and limited human resource and low funding and then lack of data and monitoring and poor political representation. All these things, they pose an enormous burden on our health services. So high disease burden, poverty and undernutrition, poor sanitation, lack of safe drinking water, diseases which are more prevalent in tribals, and lack of awareness about and access to healthcare, and social and economic barriers to utilization. All these are responsible for high disease burden. Factors contributing to increased disease burden. Just now I have enumerated poverty and consequent undernutrition, poor environmental sanitation, poor hygiene and lack of safe drinking water, lack of access to healthcare facilities resulting in increased severity and or duration of illness. Specific genetic disorders also, I have mentioned it. So older government initiatives, till June 30, 1996, there were 20,097 subcenters functioning against a requirement of 28,383 subcenters for tribal areas. The number of functioning PHCs were 3,260 against a requirement of 4,180, and functioning CHCs were 446 against a requirement of 492. So there are also 1,122 dispensaries and 120 hospitals and 78 mobile clinics in modern medicine. So dispensaries and 24 hospitals in Ayurveda, and 251 dispensaries and 28 hospitals in homeopathy. Editions after 9th 5-year plan, that is 1996, it was 9th 5-year plan, and afterwards so many editions have taken place. So 16,845 subcenters, 5,987 PHCs, and 373 CHCs have been established in scheduled caste bastis, villages. 20% or more scheduled caste population. In addition to 980 dispensaries in modern medicine, 1042 Ayurvedic dispensaries, homeopathic dispensaries, and Unani and Siddha dispensaries. For all of them, a provision has been made. Obstacles in setup. So lack of both professional and paraprofessional manpower. The state governments are trying to minimize vacancies. So a central planning committee has been set up to review the healthcare activities in UP, 39 districts of UP of 12 states. Strategies to improve healthcare in tribal areas. What can be done? This enormous burden of health services is there, but what we can do in the existing framework. So ensure availability of adequate infrastructure and personnel and area-specific RCH programs. You cannot have a uniform RCH program implemented throughout the area. 100% central plan funds for National Malaria Eradication Program and effective implementation of the health and family welfare programs, and then close monitoring, early detection of problems in implementation and mid-course correction. Some suggestions. Improvement of healthcare infrastructure. First of all, that is the most important thing. An ambulance should run from a dispensary, from a village to the at least primary health center, and then developing a flawless referral system, provide diagnostic facilities for genetic defects, follow up of anemic and other severe patients, carry out population genetic survey programs, health education, genetic counseling, marriage counseling, and provide parental diagnosis, prenatal diagnosis. Sorry. Tribal Health Development Organization. Tribal Health Initiative is a public registered charitable trust established in the small village of Stilingi in Dharmapuri district, Tamil Nadu. 15 years ago in Stilingi, 1 out of 5 babies died before they became a year old, and many modern mothers died in childbirth. The nearest hospital was 48 kilometers away, and to find one with surgical facilities meant a journey of over 100 kilometers. Today, Tribal Health Initiative runs a full-fledged 24-bed primary care hospital. So, aims of a good tribal health service: to bring all women and children through childbirth alive and well, and ensure children grow up well nourished, give easy, low-cost access to good health care, share their knowledge of healthcare with tribal communities so it becomes part of their wisdom and day-to-day experience, to attain the highest possible level of physical, mental, and social health, to create an atmosphere highly conducive for the growth and development of local cultures and customs. Ways. Regular clinics in all villages to see all pregnant mothers and children less than 5 years. Refreshing and sharing knowledge with tribal women. Tribal girls working as health workers. And postnatal checkups in all villages once a week. And health education and discussion of social problems. Dramas and cultural shows to spread information. Outpatients and inpatients seen at the tribal hospital. So these are ways. Achievements. 95% of the pregnant mothers undergo checkups. 7 out of every 100 children still die during the first year. Underweight children are only 30% compared to 50% earlier. No mothers died in childbirth last 3 years. So norms of health infrastructure in tribal areas, sub-center. In the plains area, one sub-center for every 5,000 population, but in tribal areas, it was reduced to 3,000 per 1 ANM. You can put it like that. So primary health center, the plain areas, so 30,000 were there, and in hilly and tribal areas, they have put 20,000 health centers. Community health centers, so one community health center for 1,20,000 population, whereas in tribal areas it is 80,000 population. And health worker, 5,000, 1 per 5,000 population, 3,000 population. Already I have told. So provisions of health of tribals, health guide made available for each village, incentives to doctors and paramedical staff, and then providing safe drinking water to all the tribal population, awareness of family planning, build up awareness of family planning, and then basic laboratory services, and training of local ST girls and boys as multipurpose health workers, school health program, and the anti-snake venom and anti-rabies vaccine. Regular supply, uninterrupted supply. So mobile medical unit, the mobile medical unit comprises a doctor, lab technician, nurse, ANM and driver. Vehicle is fitted with all necessary equipment including microscope and mini lab. Doctors will screen tribal people for diabetes, cardiac diseases, hypertension, leprosy, TB, etc. Agencies in the field of tribal health, Bharatiya Adimajati Sevak Sangh, Indian Council of Child Welfare and Central Social Welfare Board. New avenues are role of traditional healers. It has to be explored and their services have to be utilized to motivate the people, and training of local healthcare providers and employing health workers from tribal communities and raising awareness of health issues. Conclusion. It is necessary to continue with the primary healthcare educational activities, national health and tribal health programs, and other measures of providing support, nutrition, and counseling, and with the help from experts. So, the experts should be from multidisciplinary experts, and the health status of the tribal population can be, then only health status of the tribal population can be improved. So, these are my references. Thank you.